Thank you, Alexei. It's always a pleasure to listen to you. I think it was quite a challenge for the translator. So I looked at your... So I looked at your fine slides. It was Natalia who really wanted me to deliver this lecture, which is maybe a view into the future. And it's not as much current state of the art as what you have heard before. Now, I think here's advanced, but not on the slide. This is what it should be, the vision, that sometime in the future you go to a pharmacy and says, okay, this is my DNA, give me my medicine, which is really meant to be just for me and nobody else. So how are we getting there? Let's look on the other side of the ocean. The ASCO has issued a blue book, as you can see here, on cancer, and there they describe the transition from ordinary treating, in this case, lung cancer, to a more, how should I say, selective way. And they do this by introducing or looking at a variety of so-called biomarkers. They all indicating mutations in the genome of the tumor, and in so doing, defining subgroups of patients who can be treated. And the good thing is, this is just another representation of this, that for all of those, and here you see the percentages again, there are drugs. That is to say, right now, for these kind of biomarkers, that is mutations in the genome of these tumors, there are drugs out there which can be used today. And indeed, in lung cancer, the very first paper on so-called personalized cancer medicine was published a couple of years ago. It was a retrospective analysis. They just looked at 7 biomarkers. But as you can see here, if you had those biomarkers positive and you would receive the respective therapy, then indeed you had a better survival. Now, I will tell you about 2 studies which maybe have not been that successful, but one can learn still a lot out of it. This is the so-called Shiva study, where they looked for 3 molecular pathways. They choose 11 drugs, 700 patients were randomized, screened, 195 randomized, and then 100 versus 100, give and take, were treated. And this is the scheme. And the outcome was that there isn't really a big difference in the, I think you have to go back here on the screen. No, one further. There should be a survival curve now, which should demonstrate you. Advance 1. Okay. Which demonstrated you that the outcome wasn't very different between those who received the targeted therapy in any kind of solid tumors and those who did not. The reason being, in my interpretation, they just used 7 biomarkers and 11 drugs. And for this kind of tumors, all solid ones, maybe this was not sufficient. There's another study. This is, again, I don't know why one is doing this only to me here. Go back on the screen, please. And one more back. And one more back. Is the IMPACT trial, which was done for pancreatic cancer. And there again, one would look for a limited kind of drugs. There was a randomization, and they only used KRAS, HER2, BRCA2, and ATM mutations. They screened 100 patients. They processed 76 patients. 74 could be further interrogated. 22 were only eligible. That is 20% of those 100. And then no patient entered the trial. The reason being that it took a long time to do the analysis. Some patients died, and some didn't even want to participate in this kind of trial. For me, this is both a problem with pancreatic cancer, of course, because everybody who knows these kind of patients does know it's not a long survival. We have talked about the ones who undergo surgery today. This is a completely different story. If there's no surgery available, then, as you know, they die during a very short period of time. So the conclusion here can be that personalized cancer medicine is feasible for, say, a fifth of our patients. However, it is not available because of a variety of drawbacks. This is now from a meta-analysis of all personalized cancer medicine, and this is now regardless whether this was leukemia or Hodgkin or solid tumors. And if you look at this overall meta-analysis of some 30,000 patients, then both in the response rate, the median survival, and the progression-free survival, the personalized cancer medicine indeed shows advantages. So again, underscoring the fact that maybe we should do this kind of medicine in the future. But how to get there, and the single studies show us that this is not good to be done. You can do new studies now as an umbrella study, where you have different drugs and use this in different mutations in one tumor identity, for instance, lung cancer or pancreatic cancer, or you use a single drug on a single marker in different tumors, which is then a basket study. This is what can be done. And then again, the meta-analysis showed that there is an advantage. However, the two studies, which I exemplified for you, just also showed some drastic failures and shortcomings. Now, what to do? And I think we have to look out of the box and do this a little bit differently. The payload for personalized cancer medicine, in my eyes, is you should look at all of the available drug targets, which amount today to some 620. One should also include toxicity markers. It should be done in a cost-effective and also time-effective fashion, that is, as a panel, again, meaning just 620 or so druggable targets, so that you have a fast turnaround time. And then I think the most important thing is really to have some data mining, some software who does the interpretation of the mutations, the biomarkers coming from the sequence. Because you can't do this on your own, it's too many data. What is actionable? This is also under discussion. Shortly, it is something where you can put a drug onto it, or it could also indicate not to take a drug. And ASCO also has issued a list of some 34 drugs, as you can see here, and they're addressing some 38 targets. And those targets we call biomarkers. So in other words, the tools, the drugs to treat a patient today with personalized cancer medicine is out there. And we try to kind of bring these things now together, the sequence analysis and the drugs which you can use today. There is one more important issue to take into consideration, and that is that, that depending on what kind of marker you look at and the tumor you look at, the spread of the respective marker is rather uneven. you have, for instance, KRAS mutations in a high percentage of pancreatic cancer patients, but only very, very few, it's not on my screen here, probably not on yours one as well, say in bladder cancer. Okay, again underscoring the fact that if you have a drug and a drug target, it's not the same in one and every tumor. We have this kind of clinical process underlying the way we treat patients at Karolinska. Now this is in Swedish, but just to tell you that there is a patient-driven chain of care, and we also had the possibility to take part into a program which is called ClinSec, and that simply means that you put the next generation sequencing into the clinical setting of our routine service. In general, this means you do the surgery, at our place mostly done by Marco Del Chiaro. You get the tissue, you extract the samples, then you do the sequencing, data analysis, and in the end coming up with some kind of report to the patient. I would also like to lift the point that those here, that is the analysis part, is certified under the so-called ISO. That is to say, this is a quality control process, starting with the tissue to extract the DNA, but also doing the sequence analysis. And the software which I will introduce to you is a so-called CE-marked Medicinal Product Class 1. So that is also something which is registered and approved. And I just made this black, and we are looking under this black hood right now. And this is the black hood here, and it contains basically some kind of software engines which have algorithms which take advantage of quite a lot of databases, which I will show you in a minute. But again, we're looking at this 600 plus panel of biomarkers which can be used to take a drug or to avoid a drug. There are important things in basic science, but also in clinical medicine. Input determines output. And in our case, garbage in means garbage out. And this again underscores the fact that the quality of the material undergoing this very expensive and sophisticated things must be very good. Now, what does this software engine comprise? Well, it contains basically, and this has been built up during a 10 years period, and now there's only incremental learning. It contains, say, from the clinicaltrials.gov database, some 100,000 clinical trials, some 40,000 drugs, 85,000 variants, pathways, 1,400, over 24 million publications, and counting up as we speak. Only in cancer, every year, there is more than 1 million publications. So that's nothing you can read on an evening. Drug interactions also, and many more. And then this is an interactive thing on the web where you can look, and you have 3 categories: drugs which will be effective, those which will not be effective, and some which will be toxic. This is just a blow up here. And you also have indication whether this is already in clinical use or experimental. And you can look at the biomarkers as such, the variations, and the drugs which are attached to it. Very nice. Now, you can also look at these signal transduction pathways. This is maybe more a basic science tool for those who are familiar with the tumor biology. And this is maybe a nice to have feature. And then this in the end is a report as it would be generated by the software. And you as a physician using this would be the one who would basically determine what would go on here. For instance, in this patient with pancreatic cancer, it's a real patient, but falsified data up here. Because of the KRAS mutation and the ERP2 mutations, there was a recommendation of 2 drugs, lapatinib and trametinib, in conjunction with docetaxel. There were other drugs which should be avoided, mostly because of the KRAS mutations. And most importantly, a couple of drugs were raised like a red flag because the patient had germline mutations, the so-called DPYD mutation, which would indicate toxicity against 5-FU, but also capecitabine, and a cytochrome P450 mutation, which would indicate increased toxicity against paclitaxel, which is part of the abraxane, which we normally use in pancreatic cancer. I would also like to point out that this, for instance, is an FDA-approved biomarker. Now, how do you handle this? Well, in case you would like to use these drugs, which are part of the routine scheme which we would apply to patients with pancreatic cancer, then of course you could start with less drug, for instance, or again use other drugs. Those are experimental in the way that the drugs are registered in Europe and in the United States, however, not for pancreatic cancer. That is to say, the use of these drugs would be what we call off-label. And this creates a problem in the healthcare system because normally, of course, nobody would pay for that. Pancreatic cancer, you have heard about this. Why should we really apply personalized cancer medicine to pancreatic cancer? Well, the incidence is rising. In the year 2030, it will outgrow every other but lung cancer in the cancer-related deaths. Okay? So therefore, really, we need to do something against it. And we really try to do hard to raise this on the European level also. Pancreatic cancer is a medical emergency. Why is that so? Pancreatic cancer is not the cancer with the most mutations. But in this publication from the Vogelstein group, they have said there are 14 kind of systems which determine cell growth, differentiation, even of a cancer cell. And if you look at individual pancreatic cancer patients, in each of them, there was a mutation in each and every of these 14 pathways. And this is an explanation why the ordinary targeted drugs, which one is using with great success in other cancers, do not really have any success in pancreatic cancer. And you can see this here. These are 3 targeted drugs. This is indeed registered in pancreatic cancer. Those are available. And you can see here that the median survival times are not prolonged. Those have been stopped at the phase 2 level already in pancreatic cancer. However, what we call the tail of the Kaplan-Meier curves here to the right side, there are always a few patients who obviously profit from these drugs. Nevertheless, we cannot pinpoint those. And now with personalized cancer medicine and this software, we maybe have a chance to really identify patients who might profit from these otherwise rather effective targeted therapies. So this is again the thing which you have seen before. So we did ex post analysis here also, just reassuring us that we could find the same mutations as described by Jones and co-workers in our small group of patients, that is KRAS mutations and so forth. They also had P53 mutations, EGFR and SMAT. And then we did this analysis, which I showed to you. And here is just now the list of recommended drugs in the first 7 or so of these patients. And you can see what I've shown you from the single report a little bit earlier. The recommendation here is indeed for this combination of trametinib and docetaxel. Again, trametinib being registered but off-label for pancreatic cancer, and docetaxel can be used. Okay. Secondly, looking at the ineffective drugs, of course, quite some which you wouldn't really normally use in pancreatic cancer, and maybe more importantly then, on the toxic drugs, the ones which I also named in this one case, which I showed to you, but again underscoring the fact that those patients had mutations and biomarkers indicative of toxicity against drugs one would normally use or include in, say, FOLFIRINOX, abraxane, capecitabine is also second line, and so forth. Okay? So therefore this analysis I think is already worthwhile. So the summary here is personalized cancer medicine can be implemented in the clinical setting. At our place now the turnaround time is about 2 weeks. The analysis is producing meaningful results, both for positive recommendations, but also for negative recommendations, and also includes FDA-approved toxicity markers. Again, all the recommendations today have been so-called off-label use. From this retrospective analysis with the tools in place, we have now issued a prospective study where we do this as a so-called real-life scenario where the physicians, that is, we in a multidisciplinary team conference decide what to give to those patients. We have a health economy analysis attached to it, I think, which is very important because both the analysis is expensive as are some of those drugs. So we have the financing in place, the ethics, and also have been to our medicinal agency. This is the team, and you can see people like Marco and Chiara are really instrumental here. It's a big group of patients, of people who really go into such a study, all the way to the people doing the sequence analysis and the software analysis. So that was what I wanted to show you. And I also wanted to show you my final slide. Please come to Vienna and attend UEGW. Thank you very much.
Okay, thank you very much for this very elegant and informative presentation. So we have time for a few questions. So first of all, perhaps a comment. It's very nice to see that there is a little bit of bone and a little bit of meat now on the concept of personalized medicine, that it is actually might be possible to do it really and in practice and with benefit, which is quite remarkable. Can you tell a little bit about this kind of the software which is used? How it is generated? Is this kind of the cost implications, reality of the certification, and so on?
I mean, just to give you an idea how much data crunching it really takes. If you have a panel, and again we are talking about some 620 biomarkers, that is genes, and those with the next generation sequencing are covered by many kind of reactions. That is to say, if you talk about one gene, you may have 50 or 100 reactions which cover this gene, and you have 600 of those. Then the software will take in those data electronically, and then it will, really do the numbering, the real counting, for more than 12 hours. For a so-called whole exome analysis, where you have, some, what is it, 20,000 genes, something like that. The time the software needs really to crunch the numbers is more than 24 hours. So we're really talking about big data management here. And again, I mean, to build this up, which was a spin-off of my former workplace at the University of Heidelberg, actually at the DKFZ, it took them 10 years to build this up. These days, it's incremental feeding in. I mean, there is, of course, every day maybe a new study on clinicaltrials.gov in cancer. There's every day a couple of new papers on cancer treatment, for instance, on new biomarkers, also stemming from your research, maybe, Alexei. So these kind of things are now incremental, but it's really fed in as we speak, right? And this is used as an algorithm to really take into account everything. And the beauty is, one is not only looking, say, as in colorectal cancer, for the KRAS mutation and then taking or not taking a drug. What the software can do, and I illustrated this very briefly with these kind of signal transduction pathway, it can take into account that, say, you have a mutation in one pathway, which would be, activating, say, mutation, which would account for one drug which would block this, but you have some other pathways which are blocked, and therefore it would be ineffective to use this particular drug. And conversely, you might have a block which would tell you, okay, the drug won't work here, but then there is, circumvening this block other pathways which would tell you, well, it might be a good idea to take this drug anyway, okay? So one is not only looking at one or two pathways, it's really taking all of these networks of signaling and signal transduction into account, and then coming forward from clinical studies to really recommend drugs which might be effective. Whether this is the case or not, time will tell, for instance, with our study.
Fascinating. So what is done to archive both samples and the data?
You can take archive material, if that was your question. We at our place for many years have built a process where the tissue is going freshly under stringent standard operating procedures to pathology from the operating theater, and then the pathologist is taking her part, and then the tissue is going for biobanking, even these days for fresh making of tumor cells into culture, where we do parallel analysis, and then we take this fresh material, if possible, and do the sequence analysis right away.
Okay, thank you very much. Sure, спасибо. Are there any other questions?
Спасибо большое за интересную презентацию. У меня 3 вопроса. Первый вопрос.
Some kind of
Can you maybe?
translation.
I can try to translate
Okay,
if I
good.
manage.
Скажите, пожалуйста, с какого времени проводятся подобные исследования с целью определения чувствительности опухолей? С какого года?
So what is the kind of timing of this investigation, particularly from the point of view of the sensitivity of the tumors?
Yeah. The timing is that the patients will always receive first-line therapy, because there are standards and recommendations how to treat them in first line, both adjuvant and palliative. And
So I think that another detail of the question was how long ago it was developed.
how
How long ago this
Okay.
practice was introduced?
the software is available. It took, as I said, 10 years to build it up. You can use it today. The study we will start after the summer. And it took me 2 years really to put all of this together. It was quite a long journey.
Еще 2 вопроса. Скажите, пожалуйста, как влияет это на клиническую эффективность, экономическую эффективность препаратов? Спасибо большое.
What is the effect on the clinical efficiency and economics of the treatment?
Yeah, again, I think one has to be very careful in measuring these things, and I haven't shown you all of that. The American Society of Clinical Oncology has already identified some parameters what you should measure when you do these kind of personalized cancer medicine. Briefly, we will measure the need for additional medication, for instance, blood products, clotting factors, antibiotics. We will measure extra days in the hospital, extra visits to the outpatient clinic, these kind of things. We will, of course, measure the cost of the medication as such, but we will also measure what kind of drugs would be saved and not used. Okay. And this again is then something which certain people who have experience with these kind of calculations would take into account. This is another professional part of the study where we have people who can do this or do this for a living, these kind of health economy calculations. I'm not doing it myself.
Okay, thank you very much. I think that it is now time to close the session. So thank you for speaking.
Thank you. Pancreatitis, should the diagnosis of autoimmune pancreatitis be ruled out in all cases and voted upon if no other etiology of chronic pancreatitis can be identified in a patient, then a diagnosis of autoimmune pancreatitis should be ruled out. And it's quite easily, so there is weak evidence and also weak recommendation. Okay. Another question here is there a recommended classification system that should also be used when defining the etiology? And the short answer is no. The fun part of being involved in these guidelines really also is, if it's done well, it will create questions which can be answered in the future by us, by the community. And therefore I would really encourage you, maybe not that much read this, but it will be the newest coming out later this year, but to really look through the statements and the comments for the things you're interested in, and then come forward with ideas how one could really possibly correct these kind of deficits, which are always obvious when you are coming to do these kind of guidelines. Then maybe here in the end are the different causes of the disease, and of course, depending on the etiology, chronic pancreatitis has different disease causes and long-term complications. Strong agreement, grade 1B. Okay, so that's rather good already. For the diagnosis, then, what is the best overall imaging modality for establishing a diagnosis? Endoscopic ultrasound, MRI, and multi-detector CAT scan are the best imaging methods for establishing a diagnosis. Grade 1C, strong agreement. And then there will be comments going into the details and even nice tables, which really give you the evidence so that you can easily see what is the evidence for making this statement. Yeah? For the classifications then, CAT scan is the most appropriate, and there is not that much evidence, not that much recommendation, but a very strong agreement from the group. And for instance, one of the things where we also wanted to make something new, which hasn't been picked up by the other guidelines, is the secretine MRCP, the use. What advantage does IV secretine administration provide during the MRCP examination for the evaluation of chronic pancreatitis? And then the statement, the use of IV secretine increases the diagnostic potential of MRCP in the evaluation of patients with known or suspected chronic pancreatitis. And here, the evidence is maybe not that strong, but it was a strong recommendation and a strong agreement in the group. Okay, so that's how you interpret this. Then, as to the diagnosis of pancreatic exocrine insufficiency, how is EPI defined? And you heard some of that during my lecture yesterday, is an insufficient secretion of pancreatic enzymes and or bicarbonate function. And of course, this is excellent evidence, high grade of recommendation, and strong agreement. And then you heard about this yesterday from both my talk and the subsequent walks. What are the blood parameters to measure malnutrition? Established blood parameters for malnutrition: variable mean retinol binding protein, vitamin D, minerals, trace elements. And there is, again, not that much evidence and not that much recommendation, but a strong agreement on the statement as such. So, and then surgery. There's lots of surgery, of course, in the chronic pancreatitis guidelines, maybe not that much in the acute pancreatitis, so there is one of the areas where there was lots of expansions. In patients with symptoms of chronic pancreatitis, should endoscopy or surgery be performed? And then, there is good evidence for that, but a weak recommendation and only agreement due to the endoscopists in the panel. And the statement reads, surgery is superior to endoscopy in terms of mid and long-term pain relief in patients with painful chronic pancreatitis. And then you can read some more statements on the optimal timing for surgery. It should be done more early than late, because in late you wouldn't accomplish what you could accomplish when you do this early. There's, as you can see, through the bank, not that much good evidence, and the recommendation therefore is always weak. And the agreement for the most part is that no recommendation can be drawn from the evidence regarding the effect of early surgery on developing endocrine pancreatic function. Medical therapy then, and we covered some of that during my lecture yesterday. Again, for instance, for the dosing of the pancreatine, it's now between 40 and 50,000. Good evidence, high degree of recommendation, and strong agreement in the group. So, And then, after all of this was done, and the group has worked several rounds again and again and again on the manuscript, it was eventually sent out to external referees who had the possibility from all disciplines to give their say on those guidelines, which they did. And after taking that into account, and this is also an experience I can share with you, some of those comments were indeed rather sound, and it's sometimes surprising to see that even with a huge and balanced group of experts, you sometimes miss a thing, which also means nobody's perfect, even not such a group of experts. Finally, then we went to the manuscript. And I hope this will be ready at latest for Vienna, if we are lucky also for the EPC in Liverpool. And please come to Vienna. Thank you for your attention.
Thank you, Matthias. One question from the audience. No questions? Thank you. Thank you.
Thank you.